going to be a fun learning Wednesday because we have Dr. Alaric Aruji is here. He has been a very good friend and we have walked the way together in our alma mater, which is Wadia Children's Hospital from the early 1990s, mid 1990s, right up to now. Dr. Alaric has done his fellowship in pediatric orthopedics from USA, Singapore, Australia. He has been to most of the GATE labs and we had hosted the GATE CME together once, in the first time in 2006 and then maybe in 2012, right, Alaric? I don't remember the year now, which we did it in Ambani with Jill and Abhay. And of course, we have, he has been involved in teaching in Wadia Children's Hospital. Also, his career has been around building the blocks of pediatric orthopedics in India. So I welcome Dr. Alaric Aruji. He is presently attached to Lilavati Hospital and by Wadia Hospital for Children, and he is also the Vice President of POSI, that is Pediatric Orthopedic Society of India. Over to Dr. Alaric Aruji.
Thank you. So hi, everyone. I think most of you all know me, and I know some of you all at least. My interest besides CP, I think one of my biggest interests has always been Clubfoot. And that is something that for the last 20 years of my practice, I have been involved in. And what I'll do today is give you just a brief overview of what clubfoot treatment is at present. Obviously, I won't bore you all with surgical details and other stuff, but I'll just let you know what is the present landscape as far as clubfoot treatment is concerned, because many of you all are younger and you all have seen only a certain way of treating clubfoot, but some of the most senior ones would remember that clubfoot has had quite a pendulum of movement, moving from conservative to surgical, back to conservative, and now sort of in a stable zone where we know the role of each of these different interventions. So I'll just give you a brief overview on that. So the title of this talk is Clubfoot Treatment in 2020, and that obviously will change maybe 10 years down the line. But as far as our present knowledge is concerned, let's see where we are going with it. And that's what this Latin phrase means. Where are we actually going with clubfoot treatment? So if you look at the history of clubfoot, you will realize that it's been known since time immemorial. In fact, the earliest records of clubfoot are in an Egyptian mummy, and you must have all heard of King Tutankhamun, who's the boy pharaoh of Egypt. And when his mummy was found in the tombs of Luxor, they did a computer modeling, and they actually found that he had a left-sided clubfoot and scoliosis, which you can see in his trunk as well. So he was quite a deformed young king, but one of the richest Egyptian kings. And if you visited the Museum of Antiquities in Cairo, you'll have seen the mask of Tutankhamun and the amount of wealth that he had. If you have been to the Louvre in Paris, you'll see that there's a painting there painted by a Spanish painter called Jose de Ribera. And you can see that this child, in fact, the title of the painting is Le Piedbo, which is the clubfoot. And you can see that this child has a clubfoot here. Of course, there's been a question in history, is this actually a clubfoot or is this a right-sided hemiplegia? Because you can see that this boy also has posturing of the right upper limb along with an equinovarus deformity of the foot. It's interesting that when you look at history, clubfoot has been with us for ages. If you look at the treatment of clubfoot, I think nothing more shows us the pendulum of movement in our knowledge in medicine as the treatment of clubfoot has shown us. In fact, if you see the conservative treatment, it's not something new at all. In fact, the father of medicine, Hippocrates, in the 3rd century BC, talked about manipulating a clubfoot and then tying it up with bandages wrapped in wax and resin so as to maintain the correction. So it's so interesting to us that more than 2,000 years ago, we even knew how to treat clubfoot, and that's basically the same principles that we're following in 2020. If you were born in the 18th century, in fact, you'll be surprised to know that the treatment of clubfoot was surgical. And these two important surgeons from Germany, Delpech and Strohmeyer, in fact, were big proponents of surgeries for clubfoot. And if you've heard of Little's disease, which is cerebral palsy. Little himself had a equinus deformity, which was operated by Strohmeyer from Germany. Around the time of the 19th century, when plaster of Paris was discovered, the French people led by Guérin were big proponents again of going back to conservative treatment of clubfoot using plaster casts. And that's the first known use of plaster casts for treating clubfoot. Before that, they were being treated, as I said, with bandages of resin and other stuff. But again, towards the earlier 20th century, surgeries became popular again. And these surgeries were not like the initial surgeries, but they were far more radical. In fact, these are the names of different people, again, from the US, Phelps, Brockman, and Steindler, who recommended very aggressive surgeries, which included posterior medial releases, bony surgeries. So if you were born in the early 20th century, your treatment would, in fact, would have been surgical and not conservative. But around that time, there were pockets of people who believed in conservative treatment, and the names that we hear today, Kite and Ponseti, were both contemporaries. In fact, Kite being a little older than Ponseti, and Kite from the Texas Scottish Rite Hospital was a big advocate of conservative treatment. And a lot of what we know about clubfoot in modern times has come from the work of Hiram Kite from TSRH. But then again, in the 1970s, the pendulum swung back again towards surgeries. And again, surgeries became far more aggressive and radical. And we had this very extensive posterior medial soft tissue release. And for people who are a little more senior on this webinar, we remember that when we were doing our training, the treatment of clubfoot in Wadia Hospital was surgery. We were operating more than 120, 150 surgeries per year. In fact, that was the commonest surgery we were doing in Wadia as a fellow and as a resident, which was clubfoot surgery. We're very proud of them because these are very extensive, very intricate surgeries. You have to have a high level of skill and expertise to execute these surgeries. But then again, since the late 2000s, the Ponseti method has come back again. And as we said, it's not a new treatment. It was actually devised in the 1950s by Ponseti, who learned the method as an advance over what Kite was saying. And since the last 20 years or so, the only name that you will hear for clubfoot treatment now is the Ponseti method. So this is just to show you very interestingly, when you look back at history, how the pendulum of treatment has swung when it comes to treatment of clubfoot. So these are some old pictures that you can see. This was Hippocrates, who says, mold the foot like wax and then apply these resin bandages. There were use of some braces. At one time in the UK, the Thomas's wrench became very popular, where forcibly the foot was corrected. So you can see that the treatment again has moved from being very radical and aggressive to being more conservative. Oh, I know what's that noise. But so these are pictures again taken from Kite's book. I found this treasure in the library of KEM Hospital. And this is an old book published somewhere around the 1970s. And these are Kite's own hands showing how skillfully he molds the plaster. And I think this is the key to what treatment of clubfoot is today, that a skillful molding of the plaster, almost like a sculptor making something which is beautiful and extensive. And this is Kite's own pictures from his textbook showing you how the foot is modeled and molded well using a plaster cast. But then again, around the 1970s, as I've said, this was what was popular. And all of us as residents and fellows and training learned these very extensive procedures using a variety of incisions, either using the posterior medial approach, like you can see here, which was very popular in India, or the Cincinnati approach, which is a more circumferential approach going around the heel. And you can see how we release each and every structure. So you can see that's the talus, which is right inside there. That's the tendons on the medial side of the foot. That's the exposure of the talonavicular joint. So that's the tibialis posterior tendon pulling on the navicular. And you distract between the medial malleolus and the navicular, and the talus is buried right inside because of the dislocation of the talonavicular joint. That's a laminar spreader inside the subtalar joint, opening up the joint between the talus and the calcaneum. So you can see it's a fairly extensive release where all soft tissues which were tight on the medial, posterior, and lateral side were released. All the joints were released, ligaments were released. So it's a fairly morbid and disabling surgery, which in the long term has been shown to, if not done well, can result in poor outcomes. Around the same time, this French method became popular around the 1970s, and I visited this place in Paris. And you can see how beautifully they're manipulating the foot. For some reason, this technique didn't become very popular, but it's worth learning some of these steps. I visited the center in 2005, and I learned it from the original author. This is actually a therapist whose name I can't remember now, who only spoke French, and I could barely speak some words of French, and I could understand something of what he was doing. But the 2 weeks I spent there, I learned quite a bit of how the French treat clubfoot by very simple manipulations and stimulations. And I'll play that video again because I'm sure it'll be interesting to you. So they had various names for, it was not random and arbitrary. They had very specific handholds, they had very specific manipulation steps. They had labeled each step in French, what they were doing. And it took almost half an hour for them to do this manipulation. So it was quite an intensive thing. The child would come in every day for a half an hour session of doing this physical therapy, and then they would put the child into what they call skis. So actually, they would tie some wooden um, uh, pieces onto the foot and strap it with tape, and send those children home and come back the next day again, do the manipulation again, tie them on these skis. And they found that they could get very good correction without the need for plasters. And over the years, this technique has lost its followers. I think, except of a very few centers in France, almost around the world, no one uses this French technique any longer. But it might be worthwhile to Google it to find out something about it, because it shows some very interesting steps that unfortunately never became very popular around the world. I think for one reason, because it was too extensive and very labor intensive. So the gold standard of treatment of clubfoot in 2020 is the PONSETI method. There's no doubt about it. It has stood the test of time. It is a technique which has been there with us for almost 80 to 90 years. And it has been endorsed, as you can see, by a variety of organizations around the world, including the WHO, the American Academy of Pediatrics, the AAOS, and several other pediatric orthopedic societies. So what is the PONSETI method? Basically, it is got four important parts. It's a very specific method of manipulation to stretch the contracted tissues. It's a specific method of casting, changing the plasters every 5 to 7 to 10 days so as to hold the stretch that you have got with the manipulation. Once you've got the foot fully corrected, there's a specific method of bracing to follow up for a long-term recurrence. And before you brace them, you must do a percutaneous tenotomy of the tendon Achilles, which is required in more than 90% of children. So there are four important steps: stretching and manipulation, casting, tenotomy, bracing. And unless you've done all four of these, it's not the PONSETI method. Really sorry for this weird sound which is coming. So these are PONSETI publications, and I think anyone who's interested should read them. And I think the key publication is this one, which is the 30-year follow-up note, was published by Cooper and Dietz from his own institute in Iowa in 1995. And this was really changed and turned the tide from surgical treatment to conservative treatment, because people started realizing that the results of surgeries at 10 years were not as good as compared to these long 30-year follow-ups that PONSETI's people showed. They had much more supple feet, they were more functional, they were more pain-free, and that's why the tide of information swung towards the conservative treatment once again. And PONSETI always says that it wasn't doctors who popularized his method. In fact, most orthopedic surgeons were very resistant to this technique because obviously they love surgeries. They were getting good short-term results with surgeries. It was a fun operation to do. And it's, in fact, he attributes the parents who actually created support groups to spread the message. So it shows us how powerful lay people can be, that within 10 years, from the 1990s to 2000, the whole atmosphere swung towards the PONSETI method. And it shows the power of how lay people can incite change in society. And then he went on to publish his book, which I think all of you all should read. It's not a very big monogram. It's available as a free download from the PONSETI International Association website. If you type in PONSETI, pia.info, you'll find the book, which is available as a free download. It's got about 8 to 10 chapters in it, and it's really gives you an interesting overview of how he came up with this entire technique of manipulation and casting. But I think the key that he understood here was the goals of treatment of clubfoot. And I think whether we do the French method, the conservative treatment method, or we use surgery, the goals should not change. The aim of treating clubfoot are to achieve the 3 Ps, as we call them, to achieve a pain-free, plantigrade, and pliable foot. So if you achieve the 3 Ps, you have done your job. At the same time, he added 2 more comments. The feet should be without calluses and they should not need any modified shoes. And I still see at times children who walk around with those horrible clubfoot boots, which are reminiscent of the polio era. And people still feel that by using those clubfoot shoes, they are doing some sort of correction. And I keep reiterating to so many people whom I encounter that shoes cannot change the shape of your feet. That's a big myth. It's unless you're really tying up your feet in shoes 24/7, like what the Chinese used to do many centuries ago, where they had the concept of foot binding. That's the only way you can change foot shape. But shoes are meant to protect our feet and they're not meant to correct our feet in any way at all. So we must give up that myth of corrective shoes because they have no role to play. So these are the goals of clubfoot treatment: to obtain a pain-free, plantigrade, pliable foot, which has no calluses and which requires no modified shoes. So if you really would like to understand the biomechanics of the foot, and the way Ponseti came about with his technique is that he just didn't go one day, wake up in the morning and say, here's my technique. He was a true clinician scientist who understood that without understanding the biomechanics of the foot, I have no right to correct a club foot. So it didn't arise to him like a eureka movement, like what Archimedes went through. In fact, he did a very detailed study of the biomechanics of the foot, and he attributes 2 books which he learned the biomechanics from. Unfortunately, not available to us because they're in French and in German. But the French one was by Farabeuf, and Farabeuf actually showed and made the analogy between the calcaneum in a clubfoot versus a boat in the ocean. And just as the boat rolls, pitches, and yaws in 3 dimensions, the calcaneum moves the same way in clubfoot. And I think that's a very beautiful analogy to make. Similarly, in Germany, we had Usen, who described about the anatomy of the subtalar joint, saying that the axis of the subtalar joint is not like a mitered hinge, but it rotates around a moving axis. And the whole concept of the Ponseti movement and Ponseti maneuver is based upon these 2 principles. The work of Farabeuf showing the kinematic coupling of the subtalar joint and the closed kinematic chain of the subtalar joint, which Usen called Dikinetischkeit, which is basically show that the subtalar joint is a moving axis. And this is what is the basis of the Ponseti technique. So to look at the anatomy of the foot, so here are some models which show you how the subaxial joint axis is. And you will see that the subtalar joint axis is not planar, but it is at an angle. It's an angle of 45 degrees going from superior to inferior, and it goes 20 degrees medially to laterally. So because of this oblique orientation of the axis of the subtalar joint, as you abduct the forefoot, the calcaneum by itself will abduct, evert, and dorsiflex. And this is the key to understanding the Ponseti method, that without touching the heel, and that's what Kite didn't understand, by moving the forefoot, because of the kinematic coupling of the subtalar joint, as you can see here, so we are not touching this heel, we are moving the forefoot, and as you can see, just by moving the forefoot into abduction, what's happening to the calcaneum? The calcaneum is automatically going into abduction, eversion, and dorsiflexion. And this is the beauty of the Ponseti method, by understanding the kinematics of this subtalar joint. And that's the key to the Ponseti method. So if you look at the Ponseti method, there are 3 really important steps. One is, so depending upon the deformity, which is called the cave deformity, cavus, adductus, varus, and equinus. Cavus and adductus occurring in the midfoot and forefoot, and varus and equinus occurring in the hindfoot. By abducting the foot itself, you can correct these 4 deformities. And you follow in this fashion. First, correct the cavus by elevating the forefoot into supination. Then by abducting the forefoot to correct the forefoot adduction. And because of the kinematic coupling of the subtalar joint as described by Farabeuf and Usen, the calcaneus will also abduct, evert, and dorsiflex like a boat in the ocean, which is rolling, pitching, and yawing. And finally, the ankle equinus is short-circuited by doing a tendoachilles stenotomy to get that final correction of the equinus deformity. So these are the steps of the Ponseti method. And it has been shown over the last so many years that we've been using it, We have treated hundreds of patients by now. And we know by applying these well-molded casts, understanding the manipulation technique which PONSETI has described, we can achieve a correction in more than 95% of children who come to us below the age of 1. So this has been validated for the younger child for sure. Now the question is, how do we make this into something which is more extensive? Because the PONSETI technique is easy to learn and easy to teach, unlike these very extensive surgeries that required months of apprenticeship or even years of apprenticeship to learn how to do good surgery, here I think if you have the right training, it's quite easy to learn. In fact, in several centers around the world, it is therapists who are doing the PONSETI method. And I think you'll have a big role to play, not only in the correction, but also in the maintenance of the correction. So understanding these principles are important. So how does this relate to us in India? So if we look at India's population, we realize that assuming we get around 26 million births per year, which is as per our birth rate, we have, and assuming an incidence of 1.2 per thousand live births, we have around 35,000 children born with Clubfoot every year. That's a fairly large number. This is added to the pool of patients who have not been treated earlier. So every year, roughly, we are adding 30 to 35,000 new children with Clubfoot per year. And understanding how poor our public healthcare system is, with the government putting less than 1.5% of the GDP towards healthcare, which is really being exposed at this time of the coronavirus, we realize that we as physicians and therapists have to take the control of treatment of Clubfoot from the public healthcare system. So what we did is to realize that here we have a system which is easily learned. This is a system where many people can get cured easily. The government is not capable of doing it by itself. So almost 10 years ago, we decided to team up with certain non-profit organizations from around the world, which have set up programs in various developing countries of Asia, Africa, and South America. And we developed a program in various states of India where we would train the doctors to do the casting and manipulation. We would train government employees and healthcare workers to create awareness and refer patients to us as soon as possible. And where children could not afford treatment, to actually provide braces and free plasters at times to such children so that they could complete their treatment. And these are some of the NGOs whom we have worked with. And therefore, somewhere around 2011, we have set up our Clubfoot clinic. Of course, we were treating Clubfoot, as I mentioned to you, for the last 70 years in Wadia Hospital. But since the last 10 years, starting from 2011, we have consolidated all our club feet into one clinic, which is run 3 times a week on Monday, Thursdays, and Saturdays. Mondays and Thursdays, we see new patients. Saturdays, we see all our follow-ups for brace treatment. And that has helped us in a very large way to consolidate all our patients together so that patients learn from each other, and it becomes easier for the physician and the counselors to provide the right treatment. We also have developed an app which the counselors in our clinic have downloaded. So we use paper forms, of course, but almost all of that data is immediately transferred onto an app, which in today's day and age is very easy to use. And we know that almost all of us have smartphones today. This helps us as an electronic medical record so that we have a prospective database of each and every patient treated by us. And as of today, we have treated over 1,200 patients with the PONSETI method at Wadia Hospital. And totally in India, we have treated more than 40,000 children, which is a large number, but still not enough. So this is a tool that we use in our clinics, which helps us to document each and every patient as a prospective database so that anytime we can go back and track those records. We understand that to create awareness, you must have various training materials available. We must have parents who understand the concept of bracing, because that is really in their hands. So we have numerous flyers which are distributed to the parents, not only in English, but in Hindi and in the local vernacular language. So every state has their own brochure in their own state language, and of course in Hindi and in English. And this helps parents to get empowered to understand their role in the treatment of the PONSETI method. Because here's a method which is very successful, but if you don't adhere to bracing compliance, the recurrence rate can be quite high. We have also impregnated this treatment model within the public healthcare system. We know that more than 50% of people in the rural areas and about 30% of people in the urban areas still avail treatment from the public healthcare system, either through the district hospitals, the BMC hospitals, the primary healthcare centers. And we know that we already have these ASHA workers and Anganwadi workers who go around in various villages to raise awareness. So their role is to create awareness and to have early referral of these children to the district early intervention centers and district hospitals under the cover of the RBSK scheme, which is the Rashtriya Bal Swasthya Karikram, which has been set up by the National Health Mission. So it shows that we have allowed this Clubfoot program to permeate through all levels of society, not only in the private healthcare system, which you and I can do easily, but through the public healthcare system, which is really very challenging. And our program executives and counselors do various trainings of ASHA workers, the auxiliary nurse midwives, run programs for the parents, run programs for children in the schools. So several things that can be done. And over the 10 years that we have been working on this, various international organizations and news agencies have got aware of it. And our Wadia Hospital, I'm happy to say, has been featured on BBC, which is a rather big and proud moment for us, and also on PBS News Hour, which is one of the most reputed news channels of the US. So this is the NGO that I work closely with. That NGO, as you have seen, changes over the years. We have before initially were with Cure Clubfoot, but now we are with Miracle Feet. And you can see that they have clinics in various countries of the world. But though we think we have reached a large number of almost close to 50,000 children, this is not enough, because this is what we have achieved over the last 10 years. But we know that there are more than 150,000 children who are born every year with Clubfoot. So there's a large number that we need to reach. And our target really is in Asia, Africa, and Central and South America, basically developing countries where 80% of the population lives, and therefore where 80% of the Clubfoot cases reside. So going forward then, what we decided is that all the various NGOs, other than working separately, should come under one umbrella. So in 2003, about 20 organizations got together, and then now we have 28 organizations around the world who have partnered together to create this initiative called the Global Clubfoot Initiative. And this has been a really powerful tool, because now we have one voice. We have one standardized way of treatment. We have one standardized curriculum for teaching. And this has made things so much simpler rather than having a fractured way of treating different children in different countries. So some of the efforts of this GCI, or Global Clubfoot Initiative, have been to develop a global strategy and aligning ourselves with the WHO Sustainable Goals of 2030, where there are, I think, 19 sustainable goals, one of them being universal healthcare for all. One of the initiatives of the Global Clubfoot Initiative has been to end disability from clubfoot, hoping to establish national programs in all 105 target low middle income countries. There are 195 countries in the world under the WHO. 105 of them are our target countries, which deal with the low and middle and lower middle class countries. And our target is to reach all of them and to increase the treatment coverage from the existing 15% to 70%. And that's a rather ambitious goal, but we're hoping the next 10 years, by 2030, we achieve those goals, because at present, less than 15% of children in these developing countries are getting access to clubfoot treatment. So what are the things we do through this program? And I'm giving you an idea about this because I think all of you all have some role to play in this. For now, we are training mainly orthopedic surgeons, but I see no reason why you all have great motor skills, and there's no reason why you all can't participate even more. Maybe not to give plasters or tenotomies, but actually to help with the manipulations, to actually help the surgeons in the post-op recovery, post-treatment recovery, to maintain the correction of the feet, not just by the bracing which we are doing at present, but there are more active methods as physiotherapy, which I'm sure you all will cover in the second part of this talk. So here what we do is that we have a very structured way of training surgeons using various models, as you can see, on actual live babies to train them how to put plasters. We have a standardized curriculum of training. We have a very small number of participants per course so that we can give a more focused approach to training the doctors with the PONSETI method. Over the years, we have developed a curriculum which is very standardized, which was first developed in Africa, which is called the Africa Clubfoot Training, or the ACT model. But we're expanding this over the years to develop a more global training, which is called GCT, or the Global Clubfoot Training. And as you can see, it's very extensive. It has a very defined curriculum of lectures. There's a basic and advanced course. There are manuals which are available for going home to read back again. There are in-person meetings where we train you to do the PONSETI plasters, tenotomies, bracing, and follow-up. And going forward, we're creating even a mobile app, which is still a work in progress, working with Open Pediatrics, which is a Boston-based, Boston University-based center to develop mobile technology so that we can add this to our in-person meetings where we cover the anatomy, the pathology of clubfoot, and the various aspects of the treatment. We have also tied up with a Spanish company who are experts in making 3D models, and we have developed the first animated 3D model of clubfoot. And all this is work in progress. This will roll out in the next year or so. We're still working on this, but this is a very extensive model where you can download this on your laptop, iPad, or mobile phone, and you can actually study the anatomy of clubfoot. You can understand how the manipulation is done. We have bone models which you can play around with and swing them around in all different directions. So what I'm trying to show you here is there's a very fascinating way of learning clubfoot treatment in a very modern way of using 3D modeling apps and various other e-learning tools to spread the treatment of clubfoot. So I'll wind up by saying that over the years, we have received various grants. We have received a $1 million grant from Google to innovate in technology. We received a small grant from SICOT, which is our International Orthopedic Association, to develop a foot brace, which will help us to understand compliance. Because when we apply the brace, we expect the parents to follow the bracing schedule. But we know that most of the times parents don't do that. And there's no way we can tell that, because when we ask the parents on follow-up, how many hours has the child been wearing the brace? They say, oh, 23 hours a day. But we know that the brace is actually being used for less than 2 or 3 hours, or maybe sometimes not at all. And one of the biggest factors for causing recurrence is lack of compliance with bracing. So what we decided to do is to take up a project with IIT Mumbai to see whether we could incorporate sensors within a brace so that we don't need to rely on parents telling us that, but actually having a sensor within the brace so that we can actually track whether the braces are being used or not. And this is a study that we are doing with SICOT and with IIT Mumbai, where we are developing a sensor. As you can see, this is the miracle feet brace that we use. And we have two types of sensor: an infrared sensor to tell us that the shoe is inside, the foot is inside the shoe. And then we have a magnet which tells us that the shoe is clipped onto the brace. So two sensors which tell us that the brace is actually being worn. And that data is then transferred to a mobile app using Bluetooth and then communicated by Wi-Fi to a person sitting in the clinic. And therefore, the doctor or the counselor sitting in the clinic, without seeing the patient, through the data and the app, will be able to track whether the child is wearing the brace or not. So this is all fascinating things going forward, which will have a huge impact on the way we treat clubfoot in the next 10 years or so. And finally, the last part that I will stimulate you to think about is about the treatment of clubfoot in the walking child. Because we now know that the standard of care in the younger child is this conservative treatment of manipulation, casting, and bracing. But we do know that we have children who come to us who are much older. And I know you all have clinics in Nanded where you all visit, and you'll see patients who have come untreated to us at the age of 2, 5, or even 10 years of age. And things change in these older children. We know that bones are getting deformed, the soft tissues get more contracted. And for many years, for these older children, we were using very aggressive and intensive surgeries, fixators, and other things. But since we became adept with the use of the PONSETI method, we thought, let us try using this method in the older child as well. And here we have, as you can see, this child actually came from our camp in Nanded. She's 5 years old and she's walking on bilateral deformed feet, which have never been treated. And this pushed us to say, let us try the PONSETI method even in this older child. And since the last 5 or 6 years, we have been using this technique in older children as well. And then we said, let's put our cases together and look at the results of them. And then we published this in the Journal of Pediatric Orthopedics last year. For those of you interested, this is the reference. And we looked at various things to say, what's the success rate in these children? How many plasters do we need to apply? How do we brace these older children? And what's the risk of relapse in them? And I won't bore you with the details of that study, which you all can read in that reference which I've sent you. But just to show you a few pictures, these are two children. One is 6 years old, one is 5 years old. And just using the PONSETI method, using plasters and tenotomy and bracing, we have been able to achieve a full correction. So this shows that this is a really powerful method. We don't have to use it only for the younger child, but even in the much older child, we have success. And to wind up, here's a patient whom we treated about a year ago. She is the mother of a child who had clubfoot, and the father used to bring the child every week for the casting when she was a baby. And the feet were completely corrected. And then dad tells us, my wife has clubfoot as well, which has been untreated. And she's in a village in UP. Can I bring her for treatment? And we said, why not? So this is the oldest person we have treated with the PONSETI method. And I won't say that entirely this treatment has been with plasters only. She did undergo some bony surgery and some soft tissue, but very limited. Rather than doing the very extensive surgery that we were doing earlier, we just did a plantar fascia release, and we've done some osteotomy on the lateral side to make the lateral border straight. And this lady is now walking after 26 years of her life on a plantigrade foot, which is pain-free and which is not entirely completely supple, but it's plantigrade and it's got some mobility at least. So I think it's a fairly exciting option that we have nowadays. It's very challenging. It looks very nice when I show you these photos, but she redid several plasters. As you can see, 19 plasters in a 26-year-old woman is not a joke. But she did achieve a good result in the end. So to wind up, I would say the take-home messages from this overview that I've given you is that the PONSETI method has now superseded all other methods and has become the standard of care for clubfoot treatment. But that does not mean that surgeries have no role to play. In fact, a good orthopedic surgeon will understand that there are certain patients in whom you have very resistant or recalcitrant deformities in which surgeries, fixators, osteotomies, arthrodesis still have a role to play. But they should be really limited. And our treatment of choice should be that every patient, irrespective of the age, should undergo the PONSETI method first, make an attempt to correct as much of the deformity as you can by conservative methods. And once that fails, you can always resort to limited surgery, uh, uh, going as conservative as you can so that these patients in the end have good outcomes in the form of pliable, plantigrade, and pain-free feet. And we have shown over the last 10 years that a program-based approach that we follow in most of our centers now can really help because we have a very prospective database. We have a very good parent support group. We have counselors who advocate very strongly for this treatment in parents who do very, very detailed follow-up so as to track that we don't lose any patients to dropouts. And this method, I think, is the way that we should go about treating children in a country like ours, where we have a lot of challenges in our healthcare system. So thanks very much, and sorry for overshooting the time a little bit. Thank you.
Thank you so much, sir. So, everyone, if you have any questions, you can post it on the chat and then we can ask Dr. Alaric. Snehal, ma'am, are you there?
Yes, I'm very much there.
Ma'am, till now there are no questions on the chat.
So
Can we take the questions in the
I
end?
would like to ask Dr. Alaric. It was a wonderful presentation, and from the times we started to what we are today, there has been a big shift in the way we are managing clubfoot in the with the orthopedic way of management. What about Botox? Do we consider Botox as a form of treatment from your side? And how do we also look at I mean, what is the timeline you decide on orthopedic surgery versus a tendon? Because there's a big confusion in the minds of therapists and also parents. Soft tissue releases, orthopedic surgeries, Botox. These are the three options available. So how would you?
So Botox is easiest to answer. It has no role. There's probably a couple of centers in the world which are using Botox. It makes no sense because Botox is something which is used for spasticity. Here, there's a fixed contracture of the muscle. We know even in cerebral palsy, if you have a fixed contracture, Botox does nothing. So there's just, I'm aware of a couple of centers which are using Botox, and to my mind, it makes no sense at all. It's a waste of time. And now considering the side effects that we have discussed with Botox, and the fact that we are becoming far more conservative with the use of Botox, even in CP, we know that in Clubfoot it has no role at all. So I would discount the role of Botox completely. As far as surgeries are concerned, I would, as I said before, we have become a lot more conservative in the last 20 years or so. The pendulum has swung back towards conservative treatment, but that does not mean that surgery has no role to play. So my treatment, the way I focus and my algorithm for treatment of clubfoot is that every patient who comes to me undergoes conservative treatment first. There are various factors for success. Obviously, a child who's not been treated before, a child who's younger, a child who has not had previous surgeries will get the best results with conservative treatment. In fact, in them, there's a 95% chance of success. And that's a big thing. 95% chance is a very, very big thing. I've shown you even in older children, and those of you want can read our paper in 2019 for the Journal of Pediatric Orthopedics. We have shown that even up to the age of 10 years, they've been able to achieve results with the conservative treatment. But as you grow older, there's more a need for limited surgery. Where is the role of those very extensive soft tissue releases that we were talking about many years ago? I think it's very, very limited now. It is children who have very severe recalcitrant deformities, children who keep recurring back after conservative treatment despite casting them properly, children who have had syndromes like arthrogryposis, spina bifida. These are more resistant to correction with conservative methods. It's not that they can't work, they can work even in them. In fact, we have written up our results in syndromic children, which we have sent to the SICOT journal, which hopefully should get published this year, where we looked at our syndromic cases separately, and we found that even in them, we could achieve an 85% chance of correction, though the relapse rate was quite high in them. So for me, the role of surgery is limited. It is, and that's saying this as a surgeon. We have really found the scope of surgery is for those very small subgroup of patients in which they are resistant to treatment or had multiple relapses.
So we have two more questions. So the first one is, how do you differentiate which child requires surgery and which one of it requires PONSETI method?
So all children undergo conservative treatment first, as I've said. It is only those who are resistant to surgery, and that is a decision that we make when we apply multiple casts, that we are going nowhere. The older the child is, the more number of casts required to reach that point when we say that it's plateauing now and we're not getting any further correction, and then we consider surgery. So I wish there's one point I can tell you and say identify that and say this is surgery, but that's not the way. As I said, every child that comes to me undergoes conservative treatment first. And when I find that they're not correcting, and that factor changes with the age of the child, the younger the child, 5% chance of it not working. The older the child, the more the chance of it not working. And when I find a plateau in the severity of the deformity, we're not getting further correction, that's when we consider surgery. The second role of surgery is for recurrences. You know that some children who undergo treatment with the PONSETI method around the age of 3 or 4, as they start walking more and more, they tend to develop a dynamic supination. And in fact, in PONSETI's original series, 50% of his patients underwent a tendon transfer, which is the tibialis anterior tendon transfer. The tibialis anterior tendon is inserted on the medial aspect of the foot on the base of the first metatarsal, and that's a very strong deforming force for forefoot adduction. And if we find that is causing a dynamic supination, the word dynamic means obviously there's no fixed contracture. In the swing phase of gait, as the child is walking, we find that the foot gets kicked into adduction and supination. Then that is the time that we do a tendon transfer. The indication for that has come down over the years. As I said, in PONSETI's original series, 50% of his patients underwent a tibialis anterior tendon transfer. As of now, for us, it's about 15 to 20% of children around the ages of 3 to 5 who have a dynamic supination of the forefoot while they're walking in the swing phase, who will benefit with the tibialis anterior tendon transfer. But that's a very good surgery to do because it does not damage any joints or ligaments. It is not invasive onto the intra-articular structures. It's an extra-articular surgery which really helps to reorient the direction of pull of the tibialis anterior tendon.
Okay. So there's one more question. So is there any database for specialized state-wise centers for CTEV or district centers?
Yes, absolutely. So what we do through our program is that we sign up with the state government of each state. And under that state government, they have the district hospitals which come. So we liaise with the district hospitals in the public healthcare system. And nowadays, we even have the district early intervention centers called the DEIC, which has a new concept which has come up over the last 5 years or so. And the DEICs are specific areas where they look at 20, 30 different conditions that can affect children. 10 of them are congenital conditions, 10 of them, some of them are developmental disorders, including disability and developmental delays. So they are referred to the DEIC, which are trained to treat children from 0 to 6 years of age. So every child then who's referred to these district hospitals and DEICs undergo treatment at those centers, and the counselors or the program executives put all that data into a centralized database, which is called that system called CAST, which I told you, which is an app. CAST stands for Clubfoot Administration System, CAST, and that's a worldwide database. The data lies in the cloud, and the server is in somewhere in the US, and that database can be accessed anywhere around the world. But for that, that center has to be part of that database. So we have to sign up with that center. So you can't just say, I'm a patient Clubfoot, I want to enter the database. It's a formal MOU that is signed with the government and with certain hospitals, like, for example, Bardia Hospital.
Okay, thank you, sir. Dr. Snehal, you can continue with your PPT now. We have, yeah.
So coming to the next part, which he said and which he really mentioned, is the conservative management of CTV. I respect Dr. Alaric for his views, which he has given, and he has stated that we look at more of conservative management. Dr. Alaric not only refers the patients to us pre-PONSETI or post-PONSETI, but during the phase of development, I think Dr. Alaric definitely emphasizes that we need to have therapy as the mainstay of treatment. So coming to my talk today, all of us remember our first patient, and this was our first patient of CTV years back, and he's now maybe around 20 plus, and he's 24, 25 years old. He's an entrepreneur. He's done really well. So why treat, see, that's him now, that's him. So why treat CTV? What is the reason that we are all looking at management of CTV? So when you're looking at the child and her or his function and what, can you all see this? So she was a case of very interesting child. She was a case that come to us with bilateral CTV. Initial stages when I saw her, I felt that there was something really different in her. And I tried asking the neurophysician as well. But then again, that time it was just brushed aside, saying that nothing is wrong with her. We found that an X-ray had later on when I felt that she had a sort of a dimple and overgrowth of hair. There was a tuft of hair. So we took an X-ray which did show a spine which was bifid. You can see also that she has a short neck, and she had some amount of torticollis or restriction of range in the cervical spine. She also had her scapulae which was overriding. So we felt that she was syndromic. Finally, I think last year, the neurophysician felt that no, we should investigate her, and she has come out to be a syndrome. So when you're looking at her involvement in society, or even this child who has been, I mean, she's the same one who has been rehabilitated well now. So their function and their participation is what is very important to us as therapists. This is another child whom we have been commonly seeing with Dr. Alaric. He was also a bilateral case of CTV, referred when he was very, very young. And that is Rishi a few years later, maybe a year or two later. So in various functions which the child actually needs in his day-to-day function, The foot becomes a very important part for him. So here is Rishi. Rishi plays football now. They have still maintained a follow-up with us, needless to say. When I was looking at the papers and sort of material which was available to us as physiotherapists, there is very limited material on involvement of a physiotherapist and giving treatment. Why is it important? So this was one of the papers which I found out that there is a lower leg atrophy which we see in these children. So in 60 Clubfoot children whom they had seen, 40 children had atrophy and also they had limb length discrepancy. So this is another question that Alec can later answer. What do we do when there is a limb length discrepancy in children? So this was an interesting paper, and one more paper which I got was 2019, in which they have treated CTEV in a conservative way using physiotherapy. So these photos are from that paper, and I was pleasantly surprised and happy to see that they have involved a lot of neurodevelopment and sensory integration therapy in the children. So when you're looking at the foot, this is what Alaric already covered, and I don't want to go into details. You're looking at three different things. As a normal foot, you're looking at adduction, inversion, you're looking at plantar flexion. And why is it important to us? We have to understand, this was covered in our previous talks, that we have two pillars in the foot, the medial pillar and the lateral pillar. The medial pillar, which is made up of the talus, the navicular, the first trach, cuneiforms, metatarsals, second and third, which is the mobile side, as opposed to the lateral pillar, which comprises of calcaneus, cuboid, metatarsals, and the point of so lateral side is a point of stability versus medial side, which is a point of mobility. So when you're looking at CTV, there is a combination of both these factors which is affected, and how do we really work with it is what we have to look at. When you're looking at the development of a child, and when the child starts coming from prone to side lying, starts rocking, in crawling, trying, you can see the position of the feet. There is supination on one side, there's plantar flexion. So the muscles of the foot are constantly at demand when the child starts moving about and exploring the environment. When he starts coming to standing and starts weight bearing on the foot, again information which goes through the foot creates a lot of changes in the body mechanics and the systems, namely the NM and the musculoskeletal system, which he has to look at, and how he can develop and go into independent standing, running, kicking, jumping, etc. So that's 9 to 12 months. When he starts cruising around, he again uses one side of the foot. And when you look at the base, as NDT therapists, we know that the base is an important aspect which we look at for the alignment and for the center of mass. So if the child has an element of CTV, definitely the ABCs of posture would be affected, the way he moves around would be affected, and that's where we come into picture as neurodevelopmental therapists. It's coming up to stand. You can see that the body mass has to move ahead, so the child has to move from one point of support to the next point of support, walking with his feet, progressing into the environment as and when he can do with a greater degree of freedom. So what is the job of a physiotherapist? Number one, early assessment. Number two, early treatment. Reference to the appropriate team members. Environmental stimulation. Looking at foot dynamics. And most important part is parent counseling. Because parents again feel that what we do in therapy is not very great as much as what the orthopedic surgeon does. So there has to be a team counseling or a team communication which is happening to the parents. What is the importance of therapy and how it is readily not just the 1 hour of therapy what the parent is supposed to do, but it becomes a lifestyle of the child. So definitely we look at the neurodevelopmental approach when we are looking at CTV, which is one part of our approach. When we look at posture and movement, not only what the ankle but is showing us, but also the proximal joints. Most often we see the knee joint, which is showing us locking. We also see that the posture of the child gets affected by standing asymmetrically. That affects his function. But again, everything depends upon the family and the characteristics of the child and the intervention team who's looking after the child. So assessment, you do look at range of motion, you do look at tightness, contractures, Very important part is the plantar fascia. You look at the muscle power, what the child has, the strength. You take pedographs, you do a developmental assessment, and also look at any other associated secondary impairment. So these are pedographs which we take in the clinic. What are the aims of intervention? Number one, without good alignment, you can never progress forward. So alignment of the foot. Second, we look at the mobility of the foot. You look at proximal joint stability and control. You look at muscle strength and contraction, muscle re-education, sensory feedback through proprioception, tactile, and also we look at eye-foot coordination. Further on, gait becomes a very important part of treatment. So principles of therapy, what we follow. Till recent times, physiotherapy management in CTEV was stretching, splintage, and IG stimulations. But recent advances, more emphasis has been put on alignment, proprioception, and strengthening. So we incorporate principles of neurodevelopmental therapy, sensory integration, motor control, and motor learning. So what are the other difficulties the child would show? Problems in development, which are mainly motor. They could show a delay in milestones if associated with any syndromes or conditions like spina bifida. Other problems from the systems also surface. We look at eye-foot, eye-hand coordination, which could be affected, eye-hand also, because a child could have temporospatial issues. Child may not crawl because of the splints being in his feet. As Dr. Alric says that the splints are very important. Most of the times they go into abduction, external rotation, like a hypotonic child. Many of these children do also show hypotonia. So stages of crawling definitely could be affected. Therefore, the hand perception is affected, leading to balance and dynamics in walking, or other bilateral integration issues which could be seen in jumping, kicking, staircase climbing. So alignment of the ankle and foot is very important component of function because of the interplay of alignment and movement of the relationships between the kinetic chain components. So we do splinting as advised by the orthopedic surgeon. Taping techniques are the mainstay in maintaining the alignment. We look at proprioception, in which we see the orientation of the body parts in space. So orientation of the ankle to the knee, to the hip, to the other side of the body. How is he changing his rate and timing of movements in his function, and whether he has the required force and speed of muscle contraction and stretches. So we do active stretches using surfaces, mobilization of joints, manipulations, grade 1, grade 2, myofascial release for the plantar fascia, muscle strengthening, taping, functional use of the foot, and sensory feedback. Definitely has to be complemented with orthosis, orthopedic surgery, and reconstructive surgery. Post-surgical management, we are looking at a compromised and a corrected system. Be careful not to encourage early weight bearing. Correction has to be maintained well. We do sometimes work with Faradic re-education if advised by the orthopedic surgeon, but in that it has to be a biofeedback. We do give tactile and proprioceptive feedback. We work with proprioception. We used to work with weight cuffs. No more we do that. We do a lot of proximal joint workup, which is essential. So these are our few children. That's taping, which has helped the child. So definitely a common purpose is what we look at when we walk together. So I end my presentation here and I'm open to questions.
So, ma'am, there's one question which is pending. So, it says, it's for sir actually, does sternotomy time varies according to the child and deformity in newborns, or there is a fixed protocol?
So when it comes to tenotomy, we follow a scoring system, which I'm not covered today because it's not, I think, essential for you all to understand that. But we use something called the Pirani score. Pirani is a Canadian orthopedic surgeon who's actually an Indian by birth. And he came out with this 6-point scoring system where we score 3 entities on the forefoot and 3 in the hind foot. And basically, we're looking to see the extent of forefoot adduction, cavus, curved lateral border, talar head coverage, ankle dorsiflexion, empty heel signs. So there are these 6 signs that we use to detect the different grades of severity of the clubfoot. And that's a standardized, reliable, valid method of grading club feet. So what we do is that every time the child comes to us every week for casting, we perform the Pirani score. The Pirani score, as it starts, the maximum score you get is 6/6 and the minimum is 0/6. So we try to get a foot from 6 to 0. So every time the child comes to us, we score the foot. And what we see is that the midfoot score corrects quite rapidly with the casting and manipulation, but the hindfoot score lags behind. And once the midfoot and forefoot are fully aligned, the talus is fully covered by the navicular, and the heel is still in equinus. That is the time we do the tendo-Achilles tenotomy. So there are a couple of signs that we use to diagnose when to time the tenotomy. And as I said, the three important factors are when the talus is completely covered by the navicular, when the lateral border is completely straight, which means that the forefoot adduction has been corrected, and there is still some residual equinus of more than 10 degrees. That's the time when we decide to do a tenotomy. So we use the Pirani score as a surrogate to decide when a tenotomy is required.
Thank you,
I
sir.
would like to share a video if it is possible. Someone has asked about taping. So I'll try. That video is not coming into save. Close.
So while you're setting up that video, I will say a couple of things, that we have so many people logged onto this webinar. And I would like someone to actually go through your therapy literature, because I know in orthopedics, there's hardly or maybe no reports at all of the role of physiotherapy. If someone can do a literature search through your physiotherapy journals and find out, is there any report of various different strategies used by therapists in the treatment of clubfoot? All these things that Sneha has talked about, the taping, the strengthening, alignment. And if there isn't any literature, I think you all must report your results, because this will be a game changer when it comes to clubfoot treatment. As of now, the whole world is focused on casting, manipulation, tenotomy, bracing, but there's very limited information available on the role of therapy. And I think you all are doing so much, and I've definitely seen that the results are so much better when therapy is added to the treatment armamentarium. And I think someone needs to look into that and really report that, because that will change the way we look at the treatment of clubfoot.
Can you see this video? Is it visible?
Yes, ma'am.
So this is a taping video for Rishi, which I had done. You can see the left side has already been taped. A small video just to show you all. Someone asked about kinesio tape. So I had done this for his foot and also for the knee. And Rishi has really done well with the knee recurvatum which we used to have. The right foot has almost got corrected, and Dr. Alaric will agree that he was a very resistant case. Rishi. So you have to take care that you don't wrinkle the tape. There are a few more videos I can show you all. Yeah, this was his home program. Someone asked me about myofascial release. I hope this is the one with myofascial release. Yeah. Just for your support. Can do it without it also? Those are the mobilizing.
Ma'am, we can't hear you.
Did I disappear from the meeting?
Yes, ma'am.
Okay. So that's the myofascial release because he had really tight muscles. And then we move on to his, this is an entire program which we can show you how we had used different surfaces. So using surfaces, textures, focus is always the foot and how he moves onto the foot. Okay, so these are the few excerpts which I could show. That's it. Yeah, mobilization can be done, but with great caution. People who have not handled infants, I would not advise them to. Ma'am, how do you strengthen proximal muscle strength and proprioception in children? Functional and isolation both. It depends on how good the child and how cooperative the child is. You have to be really, really tricky and oriented with a lot of fun based activities. So usually functional activities. If you're doing isolated muscle strengthening, you have to do it also follow up it by in function as well. Taping is done for, it is not about the components in taping. We first again look at the alignment, we look at the activation, we look at the inhibition. What purpose are you doing the taping for? For what goal are you doing the taping for? So taping it by itself is very individually decided according to the case. But as Dr. Alaric suggested, I need to standardize the taping methods, and there's no paper as much as I have read, and I have gone through literature yesterday, Alaric. Yesterday night, I was looking through whether we have physiotherapy, any literature in physiotherapy. There's only one paper which has come up in 2019 in Spain. Other than that, there has been no literature of the role of physiotherapy in CTEV. So that's an open field for us to really document and come up with work.
Ma'am, there's one more question. So when can we start weight bearing after the PONSETI technique has been done?
So I would say definitely depends on the muscle power. Very early, no. Slowly start with giving them weight bearing on the surfaces. Maybe again, if I would show you all, we have done that on our, okay, share screen.
I will just add here that most of these children we are doing the PONSETI method on are less than 1 year of age. At Vardia itself is a public hospital. Almost 80% of our or 90% of our patients are 1 year or less than 1 year. So really weight bearing is not something that we're talking of very early in these children. Most of them are treated at birth. By the age of 2 or 3 months, the feet are fully corrected.
So I think are the shoes which are given. And our activities post that, you can see the correction. So we start with activities like this with a...
Ma'am, we can't see the video.
It's not the video, it is just a photo. You can't see this?
No, ma'am.
No, ma'am.
No? How do I show that to you all? Share screen. Okay. Is that good? So that's how we start initially with little toys, small equipment, what we have. This can be seen, Mihika, yes or no?
Yes, ma'am.
Yeah, ma'am.
The picture can be seen.
Yeah. There's no video. We don't have videos in that. So we have, we start like that, and then slowly we build on from where the muscle re-education starts and muscle power starts. Any other questions? And one piece of advice I would like to give, that many of these kids are kept into the plasters, and they are into their splints. So mobility becomes a big issue. So I would say that we should go ahead with giving them NDT, even if it's of the proximal components. I definitely believe that therapy should not be stopped and they should not be just kept immobile at home, because it definitely affects their function when they come to us later on.
Ma'am, there's just one question pending that says, till what age it is normal if the child works with the medial weight bearing in normal development?
In normal development, as we had discussed, medial weight bearing comes in the maybe the initial stages when he starts at 9 to 10 months, he starts standing. The moment he starts weight bearing and the base shifts to the lateral aspect of the foot, I think he should not be into medial weight bearing or into pronation. So if you're looking pronation, maybe after 1.5 years of age, we have to be a little bit having a caution, though many of the pediatricians do tell the parents that you all can neglect it. I would say treat it with caution, definitely. Alaric, any comments on that?
So medial weight bearing is rare in clubfoot. In fact, most of them will laterally weight bear.
No, this is, I don't think they're asking about CTV. They're just asking generally about medial weight bearing. I hope that's a question, right? About normal development.
Yeah. So in which case we are also looking at the age of the child, because some of the very younger ones have just a pad of fat around the arch, and the arch is not visible because of the fat which is present there. So especially chubby children, when they initially start walking, will have a flat foot gait. I think more importantly, I look to see where the calcaneum is. I don't worry so much about the medial arch as much as I worry about the calcaneum. If I see the calcaneum going to significant valgus, then I get concerned enough to put a medial arch support or, whatever is required to correct that, to work on the alignment. But as long as I don't see the heel in valgus, if I see it in neutral or in slight varus, then I don't get so concerned with medial weight bearing.
Another thing consideration is the tone, again the proximal and proximal alignment of the hip, the knee, whether you're seeing any more factors there, all these factors definitely count.
Yeah, so ma'am, we are done, sir. We are done with the questions from people.
Great. All right.
So,
Thank you so much.
Thank you, Dr. Alaric. It was really a wonderful talk. And
Thanks. You too. In fact, there's always something to learn. And I'll only make one plea to the end of this, is that you must get your therapy protocols standardized, because that is the key. And once we have that, then you put together a group of patients, study them in detail, and then publish them, because I think that will really change the way we look at clubfoot treatment. The focus has been so much on static casting, static bracing. No one talks of the dynamicity, and we know that movement is life. We know everything else in orthopedics, we talk of movement. And yet when it comes to clubfoot, we are constricting those patients in plasters, which is of course necessary, but later on in braces, which is really not necessary. If we can get something dynamic and we can show that we keep feet moving, I think that will be a game changer in club. So that's the only plea that I would have to all of you all are doing such wonderful work in this.
Yep. So we'll develop it, I think, in the lockdown phase, almost at the end of, I hope we are at the end of it. We'll try to do something together.
Sure.
Thank
Great.
you.
Thank you so much.
Thanks.
Thank you, sir. Thank you, ma'am.